Hello, everyone. Thank you for joining us today for our webinar on Billing Code Refresher for Family Physicians in the FHO model. Let me start by introducing myself. My name is Maral Tanassian, and I'm the Director of Client Success at Dr. Care. Dr. Care is the largest provider of billing and practice support for over 2,500 physicians across Canada. On average, we have helped doctors recover $25,000 to $30,000 of revenue per year. We also support approximately 25% of all FHOs in Ontario. Our solutions and our services are designed to help doctors ensure that they are optimizing their practice, maximizing their revenue, and improving patient care. Just so you know, all attendees are in listen-only mode. We are recording this webinar, so it will be available to you after the event. If you have any questions during the webinar, please submit your question in the Q&A feature. Your questions and your identity will be kept confidential and only seen by our team. You're also welcome to send us any questions you have to info@drcare.ca after the webinar. Following the COVID-19 pandemic, many doctors have expressed the difficulty of readjusting to the billing codes that they previously used before the outbreak. In today's webinar, we are going back to the basics and providing a comprehensive overview of the essential codes you should be using in your practice. We will start with how to roster your patients using Q codes. Then we will provide an overview of the in-basket and out-of-basket codes and dive into the billing requirements. Lastly, we will look at the frequently occurring errors and provide an explanation of the latest VJ7 error code. The Ministry of Health requires that every patient should be enrolled to a family physician, as being rostered results in a better doctor-patient relationship. As you may know, the number of patients rostered according to the ministry may be less than the number of patients you have rostered according to your EMR. This can occur due to several reasons, including patients accidentally rostering with another doctor at a walk-in clinic, the rostering codes, such as the Q200 or Q202, being rejected or never being submitted in the first place, patients falling off your roster without your knowledge. It is important to identify the discrepancy between patients rostered according to the ministry against patients you believe to be on your roster to ensure that you are providing the best patient care and are getting paid for the care that you're providing. So how do you roster patients? To roster a patient, you must submit the Q200 code or the Q202 code for long-term care patients. As FHO physicians, you will receive approximately $200 per rostered patient per year. If you need additional support with managing your roster, we can absolutely help. With our latest offering, Patient Care, we can help you analyze your roster and enroll patients on your behalf. If you would like to learn more about this offering, please feel free to email us after the webinar. Under the FHO model, physicians can bill in-basket or out-of-basket codes. In-basket codes include services that physicians are required to provide to their rostered patients. These include general assessments, minor assessments, consultations, counseling, and so on. Since physicians are paid through capitation for their rostered patients, they are paid 19% of the fee value of an in-basket service. Out-of-basket codes are services that are not included in the in-basket services and therefore are paid out at 100% of the value of the service. These include services such as repeat consultations and reassessments, group counseling, form completions, and disease-specific counseling, such as diabetes, congestive heart failure, smoking cessation, palliative care, and many more. Billing the appropriate out-of-basket codes for the services you provide is important in ensuring that you are paid for the full value of the service. Doctors miss out on a higher revenue potential when billing an in-basket code for their rostered patients when they could have billed the appropriate out-of-basket code. Let's go through some key definitions that will be helpful for you to understand the codes that we will discuss later in the webinar. Assessments are encounters with a patient in which a history and physical exam is performed. Assessments can be provided virtually or physically at a place other than in a patient's home. Counseling is a patient visit dedicated solely to an educational dialogue with a physician. Many of these codes are timed and can only be billed if physicians complete the required time allotted for the service. Consultations are assessments requested in writing by a referring physician or nurse practitioner who has professional knowledge of the patient and identifies the consultant physician as competent to give advice. Let's begin by introducing some of the most common in-basket codes. These codes are associated with the services that physicians must offer to their rostered patients as part of their patient-physician relationship. Physicians receive 19% of the fee value for each in-basket service they provide. The first in-basket codes that we'll cover are some of the common assessment codes. You may be familiar with the minor assessment, the A001, and the intermediate assessment, the A007, as physicians bill them on a regular basis. So we won't go into detail about them today. Let's talk about the general assessment, the A003, as we do hear a lot of confusion around this code. The A003 requires a full history and an examination of all body parts and systems, and may include detailed examination of one or more parts or systems. These do not include breast, genital, or rectal examination where not medically indicated or refused. The code is limited to one per patient per physician per 12-month period. Let's look at an example. A non-enrolled patient comes in for a visit relating to pain they are experiencing in their joints. The doctor examines the patient's joints and reviews their medical history. What code do you bill? Because the doctor is completing a whole visit plus the physical examination, you would bill the general assessment code, the A003. Because the service provided is very detailed and in-depth and was provided to a non-enrolled patient, you will be paid 100%, which is equal to $87.35. Periodic visits are age-based visits performed after a patient's second birthday, rendered to patients that present no apparent acute physical or mental illness. There are specific K codes that can be billed depending on the age of the patient for periodic visits. The service must include an intermediate assessment, a level 2 pediatric assessment, or a partial assessment focusing on age and gender appropriate history, physical examination, health screening, and relevant counseling. Please note that periodic health visit is limited to one per patient per 12-month period per physician. Here's an example. A patient who is 16 years of age comes in for their annual physical examination. Which of these codes do you bill? Since the patient is between the ages of 16 to 17, you would bill the code K130 in this scenario. Looking at counseling codes, there is one in-basket code that physician can bill, the K013. The code is billed when a physician provides at least one unit of counseling service. It can be billed up to 3 units per patient per physician per year. For example, a physician spends 20 minutes providing knowledge and information to an enrolled patient who has just been diagnosed with gout. What code do you bill? Because the physician is providing education to the patient on a topic, they are going to bill a counseling code. Since counseling codes are time-based, we need to build a code that fits within the unit requirements. Based on the table in this slide, the 20 minutes fall under 1 unit. So you would bill the K013 code for the visit, and you will be paid 19% of the in-basket code for the enrolled patient, which would equal to $11.22. Another in-basket code that we want to cover today is the G365 for PAP. Pap smear is a routine procedure limited to 1 patient per 33-month period. From our experience, we noticed that many physicians are not aware that the G365 code is not eligible for payment when performed in conjunction with a consultation, repeat consultation, general or specific assessment, reassessment, or routine postnatal visit. This code is payable with an intermediate assessment and periodic visit. Additionally, when pap smear is performed outside of the hospital, you can bill the E430 code, the TRAFE code. Since the procedure is limited to 1 patient per 33-month period, you will bill the fee code G394 for any additional assessments. As you can see in this table, the G394 is billed for a repeat PAP procedure in case the first one came out abnormal or inadequate. The tray fee code billed alongside the G394 is the E431. For example, a patient comes into your clinic for a PAP test. The results come in and the doctor requests the patient to come back in a couple of months for a retest. What code do you bill for the second PAP test? Because the patient must come in for a retest shortly after their PAP, they cannot bill the G365. Instead, they would bill the fee code G394 along with the tray fee code E431 because it was performed outside of the hospital. Now it's time to dive into the out-of-basket codes. As I mentioned earlier, it is important to be familiar with the appropriate out-of-basket codes for the services that you provide to ensure that you are paid for the full value of the service. Using an in-basket code instead of billing the equivalent out-of-basket code will result in missed opportunities for higher revenue. The following chart demonstrates the main consultation and assessment codes that are in the out-of-basket category. The A002 code is billed for an enhanced 18-month development assessment. The A004 is the general reassessment code. A005 and A006 are the consultation codes that require a referral for the physician to be able to bill them. Let's look at an example. A physician sees a patient who is referred to them from another physician for their weight loss management. What code do they bill? Because they were referred from another physician, you would need to bill the consultation code. Since it is the first meeting, you would bill the A005 consultation code. Let's go through another example. The same patient from the previous example comes back again within the year for another session with the same issue. Now what code do you bill? Because they came back for the same problem within the year, you would bill the A006 which is the repeat consultation code. Additionally, a considerable number of time-based counseling codes are paid out of basket. We shared these codes earlier. The K033 counseling code is billed after the K013 counseling code has been billed 3 times for the same patient, while the K040 and K041 are the group counseling codes, with K040 billed the first 3 times and the K041 billed subsequently. The time unit for these codes is equivalent to more than 20 minutes, and they're limited to 4 units a year or 2 a day. For example, a physician spends 47 minutes providing knowledge and information to a patient who has just been diagnosed with heart failure. The patient comes back again a month later for another counseling session about the same medical condition for 50 minutes. What code do you bill? Because the physician provided 4 units of counseling with this patient, you would bill the K013 for the first 3 units and then the K033 for the 4th unit. We have recently created a quick reference guide on time-based codes, which you can find on our website in the resources library. Now, let's dive deeper into some chronic disease management out-of-basket codes that we want to spotlight. The first code is Congestive Heart Failure Management Incentive Fee Code, the Q050, that can be billed once per year for enrolled patients diagnosed with heart failure. The code may be submitted separately or in combination with other fee schedule codes for a rostered patient, and it can also be billed without a patient visit on the same service date. Please note that prior to submitting the Q050, it is required to have at least 2 patient visits with the 428 diagnostic code in the last 365 days. Billing the Q050 also requires completing a flow sheet to be maintained in the patient's records. Here are some best practices to effectively manage the care and billing for your congestive heart failure patients. 1. Pick a date in the year when you update your patient's heart failure flow sheet and bill the Q050. 2. Generate a list of heart failure patients to assist you when billing your Q050. And 3. Set up a reminder in your EMR for patients who are overdue for Q050 billing. If you would like to download the congestive heart failure flow sheet, it is available on our website, also in the resources library. Now, let's see an example. A patient comes in for the first time for a minor assessment related to their congestive heart failure management. What code do you bill? You would need to bill the A001 with diagnostic code 428 for the first time visit. Again, as a best practice, after the second visit, you can fill in the flow sheet within the first year of the first visit and then bill the Q050. We also recommend billing it in an after-hours shift, as you can bill it alongside the 30% after-hours premium code, the Q012. Let's now look at diabetes. The 3 main fee codes that physicians bill on their diabetic patients are K030, the Q040, and the K029. As these codes are out of basket, physicians are paid 100% of the value for this code. The Diabetes Management Assessment Code, the K030, is a service payable to the most responsible physician for continuing management and support of a diabetic patient. The code is billable up to 4 times per 365 days. The code requires a lab requisition for blood work, as well as the completion of the diabetes flow sheet, which is also available on our website to download. The Diabetes Management Incentive Code, the Q040, is payable to physicians who provide ongoing management using a planned care approach, consistent with Diabetes Canada's guideline. This incentive code can be billed upon completing 3 K030 assessments in the last 12 months and is billable on an annual basis. And lastly, the insulin therapy support fee code, which is the K029, is payable to physicians who provide support and counseling on intensive insulin therapy, requiring at least 3 injections per day, or using an infusion pump, or training on insulin for patients who use glucose meters, insulin pumps, or insulin pens. Similar to the K030, this code requires the completion of blood work and a diabetes flow sheet. The fee code is limited to a maximum of 6 per patient per 12-month period. Please note that the K029 cannot be combined with the Q040 incentive code when billed. Let's look at an example. You see a diabetic patient for the first time. What service fee code and diagnosis code do you bill? For the first time visit, you would bill the K030 with diagnostic code 250. Again, we want to emphasize that this code can only be billed 4 times during a 12-month period. A lot of doctors think it is from January to December, but the 12 months starts when you bill the first K030. Now, let's talk about another set of out-of-basket codes related to smoking cessation. When managing smoking cessation patients, physicians can bill for 3 incentive fee codes: the E079, the K039, and the Q042. The first one is E079 for the initial discussion with the patient. The E079 is an add-on code that is only eligible for payment when rendered with one of the following codes, such as the A001, the A003, the A004, etc. The most important requirement is that you must document the discussion in the patient's medical record using a flow sheet that aligns with best practices. The E079 can only be billed once per patient, regardless of their enrollment status, per 12 months. The K039 is the smoking cessation follow-up visit. This code can only be billed after the initial discussion, the E079, happens. Please note that there is no specific time requirement for the K039, so it is one of those K codes that doesn't need to define the time of 20 minutes. However, you will need to document what is discussed, and it has to be fully dedicated to smoking cessation counseling. The K039 is limited to a maximum of 2 services in the 12-month period following the E079. With the Q042 smoking cessation counseling fee add-on, you would typically add this onto the K039 follow-up visit code that you're billing, as it's an additional incentive payment for physicians to provide that counseling sessions to patients that are rostered. So here, if you bill it on a non-rostered patient, it won't get paid, but it should help you focus on your rostered patients and give this kind of counseling to them. Similar to the K039, the initial discussion code, the E079, has to be billed before the Q042, and the add-on should be billed within the 12-month period following the service date. It's limited to 2 in the past 12 months. We have a comprehensive smoking cessation reference guide with a link to the flow sheet that we will share with you after this webinar. Here's a true or false question. A doctor asks the following 3 questions during a periodic visit. Are you a smoker? Do you plan on quitting? And if yes, when do you plan on quitting? The physician can now bill the E079. Is this true or false? The answer is true, because they asked required questions which is within the eligible visit, they can be added onto. Let's move on to palliative care. The codes most billed by primary care physicians when billing for palliative care are the following. The Palliative Care Support Code, the KO23, which is payable to physicians for palliative services provided in the office or at home. If provided at home, there are rules and additional codes you need to bill based on time and day, which we cover in some palliative care resources available on our website. Please note that the KO23 is a time-based code that requires at least a 20-minute service to be paid. To be paid accurately for this service, please remember to document your start and stop times with the patient. The telephone management of palliative care code, the G511, is the code that you bill when providing palliative support over the phone to the patient or family. This service is limited to a maximum of 2 services per week. Now, the palliative care case management fee, which is our G512, is a case management code you can bill when you provide supervision of palliative care to a patient for a period of 1 week, starting at midnight on Sunday. Providing this service includes elements such as monitoring the condition of the patient, ordering tests, and interpreting test results, having discussions, providing telephone advice to the patient or their family member or representatives, as well as arranging for assessments, therapy, and coordinating community and hospital care. Please note that the previously mentioned telephone management of palliative care code, the G511, is not eligible for payment when rendered during a week that the G512 is rendered. Moreover, the G512 is limited to a maximum of 1 per week per physician. And finally, we have the A945 palliative consultation code, which you would bill if another primary care physician referred the patient to you for further support. And the minimum time required for this service is 50 minutes. If you are interested in knowing more about how to bill the palliative care fee codes and maximize your billings, we have a dedicated blog that you can find on our website in the blog section. Here's an example that helps differentiate between the KO23 and G512. A physician is providing emotional and pain management support for a patient who is in their final stage of life and no longer receiving treatment. The appointment lasts for 20 minutes. What code do you bill? This question can be a bit confusing. On the one end, we find physicians confused about the difference between the KO23 and G512, and on the other end, they often just opt to bill for the KO13 counseling code. First off, the difference between the KO23 and the G512 is that the KO23 is billed when you are providing medical care and emotional support for that patient during the final stages of life. The G512 is the case management code you can bill when you provide supervision of palliative care to the patient for a period of 1 week, starting at midnight on a Sunday. And then for the KO13 counseling code, although you can bill the KO13 for the service provided, it is more appropriate to bill the KO23 code because the physician is caring for a palliative patient. Additionally, when billing the appropriate out-of-basket code, they will receive more than if they billed for the KO13 code, as that code is in basket and the physician is only paid 19% of the fee on rostered patients. As shown in the table, the physician is paid 19% of the fee amount when billing the in-basket code, but when they bill the out-of-basket code, they would receive a higher return. So in essence, the answer to the question is that you would bill the KO23 for the service you provide to the palliative care patient. Let's switch gears and talk about our last out-of-basket code, the Q888. The Q888 is a weekend access fee code that allows physicians to bill for services provided to their group's enrolled patients for unscheduled visits on Saturday, Sunday, or holidays. Some billing requirements: the patient must be enrolled to the FHO group, the service provided is an unscheduled visit, virtual visits cannot be claimed, the billing physician must offer at least 3 scheduled visits within a 3-hour block, and the Q888 must be billed with a valid diagnostic code. Please note that the Q888 is applicable for enrolled patients only. Services provided to unenrolled patients during this block would use the most appropriate fee code as per the schedule of benefits. So for example, an A007. In addition, the Q888 code is an out-of-basket code, so the physician will receive the full amount submitted. Speaking of the difference between the Q888 and the A888 codes, with the A888, you are not allowed to have any patients scheduled. The office will have to operate as a walk-in clinic and accept patients with time-sensitive matters, which is considered emergency department equivalent. However, both physicians are required to offer both scheduled and unscheduled appointments to the patients during the after-hours block as per the FHO agreement. The Q888 allows for physicians to schedule patients, and they can bill the Q888 for seeing unscheduled enrolled patients, provided that the 3 appointments were booked or 3 slots were reserved for scheduled enrolled patients. Therefore, physicians should not bill the A888 during required weekend and holiday after-hours clinics. When the minimum required weekend after-hours blocks have been met by the group, the A888 can be billed. The question we often get is, when do I bill the Q888 code? And here's a table illustrating what code to bill for enrolled or non-enrolled patients for scheduled and unscheduled visits. As you can see, for the specific type of patient, there are certain codes that you can bill for required weekend after-hour blocks and weekend once the after-hour blocks are met. This wraps up our explanation of some of the essential in and out of basket codes you might use in your practice. I hope you found that helpful, and if you have any more questions related to these or any other codes, please feel free to reach out after this webinar. Now that we covered the in-basket and out-of-basket codes, let's go through some common errors that we see billing the codes mentioned earlier. These are our top 3. First off, the EH2 error code, which is the invalid version code. In order to fix this error, you must verify the version code is correct and up to date and resubmit the claim. The next code is the M1. The maximum fee allowed or maximum number of services has been reached. To fix this error, you must resubmit alternate fee code or write-off fee codes if not applicable. And lastly, the D3, the service fee code is not allowed in addition to the visit fee. This code is dependent on the specific claim that you submitted. You must review the code payment rules in the schedule of benefits and fix or settle the claim accordingly. Now that we know what the common error codes are, let's look at some real examples and when they occur. A physician sees a patient for a diabetic visit. This is their 5th visit during the 12-month period. They receive an M1 error code on their RA. How do you fix this? The physician is receiving this error because they have maxed out on their K030 diabetic code. The code can only be billed 4 times during a 12-month period. To fix this code, it is recommended to switch to an assessment or another appropriate fee code for the visit. We'll go through one more. A doctor billed the K030 with the general counseling code. This results in a D3 error on the K013. How do we fix this? To fix this, a remittance advice inquiry would be required to rectify the claim if doctor chooses to claim the K030 instead. A doctor cannot bill the diabetic management code in combination with the general counseling code. This is why they received the error D3. So the best practice here is to choose which service code best reflects the patient visit. As you may know, the ministry has adjusted the timeframe for claim submissions from 6 to 3 months. Starting April 1st, 2023, physicians have only 3 months from the service date to submit their claims. Otherwise, these claims will become stale dated. The ministry introduced the VJ7 stale dated error code, which replaced the W3 explanatory code. This code will alert providers that a claim was submitted more than 3 months from the service date. However, the ministry has recently updated its process for reviewing stale dated claims to allow claims submitted within 3 months of the date of service that reject to an error report to be corrected and resubmitted after the 3-month claim submission timeframe. In such cases, the provider must submit the supporting documentation, including a copy of their error report and claim identifying data, to demonstrate that the original claim was submitted within 3 months. Claims should be resubmitted as soon as possible after the rejection date to ensure payment of eligible claims. In order to fix the OHIP error VJ7, you would need to do one of the following. So if the date is incorrect, update the date and resubmit the claim. If the service date is correct, follow the stale dated claim process and resubmit the claim. If you have any further questions regarding the stale dated claim resubmission process, please feel free to reach out to us and our team will be happy to assist you. As we arrive at the end of this webinar, let's go through some key takeaways for today. So first off, physicians receive about $200 per patient per year in capitation. As long as they are on your roster, you will be paid each year as long as you are their primary physician. That is why it is so important to ensure that the patients being seen in the FHO are actually on your roster. When it comes to in-basket and out-of-basket billing, understanding the payment process is essential. Using the appropriate out-of-basket codes for the services you provide is important to receive the service's full value. Doctors may potentially miss out on higher revenue potential when billing an in-basket code for their roster patients when they could have billed for an equivalent out-of-basket code instead. Moreover, being aware of the most common errors that happen when billing these codes to help you avoid rejections and maximize your revenue opportunities. It is also important to be aware of the new 3 months deadline for claim submissions and how you can fix these error codes and resubmit your claims. Most importantly, please remember that we are here to help. We offer a broad range of services, including practice optimization, billing support, error correction, roster management, and patient recalls. Each of you is unique, and we take the time to provide a product and service that is specifically tailored to your individual needs. Rest assured, when you work with Doctor Care, you will always have a dedicated team member available to support you and address any concerns you may have. We hope you found our webinar useful, and thank you all for attending. We are offering an exclusive promotion to all our attendees today. For a limited time, we invite you to book a complimentary billing assessment with one of our expert team members, where we will do a complete audit of your medical billings to identify challenges, areas, and opportunities for improving your process. Please do contact us at info@drcare.ca to get started. That's the end of our webinar. On behalf of Doctor Care, thank you for joining us today. If you have any questions or have feedback on this webinar, please feel free to contact me at any time. My contact information is listed on this slide. Have a wonderful day.